I'm Mark Farmer. I'm the care representative on what's called the Equalities Taskforce at the college. And I've been involved with co-production pretty much through my whole working life. So working with rural communities around social isolation and urban communities and the difference and diversity that I had within those areas. So I have a long record of being involved in equality, diversity and inclusion, and also in co-production. Next slide, please. So we felt, following all the conversations that we've been having with you, that it would be really good to really have a good focus on co-production. And I just wanted to do a quick sort of reflection on what co-production should look like if it's going well. So for me, and if you look at the definitions out there, it's about patient carers, service providers and commissioners coming together to transform and redesign services. But that's underpinned by everybody being an equal partner. So it means in project teams, there being a very clear and defined role for patient and carers in there that will be co-producing. I would underscore the point that it's a very value-driven approach, because actually what sits at its very heart is that power that providers and commissioners have, and the need to share that with patient and carers so that there's that co-ownership of a service as it develops. Just wanted to take you over to the left of the screen. So many of you will have heard of the engagement and involvement ladder of participation, as we call it. And you'll see that we have at the very bottom coercing. It then moves on into educating, informing, consulting, engaging, co-designing, co-producing. Co-producing sitting at the very top. And you'll see that the ones in purple are called doing to. So that's doing to individuals and communities. Doing for, so you're coming up with the solutions and then going, do you like these or you don't like them. And then the ones in the orange, which are co-design and co-production, which is all about that doing with that I described, being at the very top of the ladder of participation. So I've outlined sort of the concept of co-production being that shared relationship and co-ownership. I've shown you where it sits in the ladder at the left. I just wanted to reassure you all actually though that you can't co-produce absolutely everything. And that is because, for example, in mental health, there are targets, there are financial incentives where the government literally says, you will spend X amount of money in this way. A kind of current example of what's going on in this is the new targets that will shortly be published around urgent and emergency access to mental health services. And that's where it talks about there being a 2-week treatment window in which treatment must start for somebody who's got urgent or emergency needs. Now, that's a non-negotiable. That's literally what will need to happen. So you can't really do much co-production around that. What you might be able to do though is co-produce or co-design what that treatment actually looks like for those people. So just wanted to really make sure that there was that understanding of we can't co-produce absolutely everything. And I've got to say, unfortunately, there are very limited examples of true co-production. There are many fantastic examples of co-design, but there are limited examples of that co-production. And that is because there's many different factors which we're going to discuss in a minute. Next slide, please. Just really wanted to very quickly reflect on why I do co-production. So it's not it just being a nice thing to do. It's fundamentally a way of providing services in a different way. So all of the research that I've looked at, the work that the Royal College has done, shows actually that if you do it in this way, you end up with more cost-effective, responsive, and high satisfaction rates. And most importantly, health outcomes from people using it really do improve. I just wanted to give you an example. So where I am in Leicester, Leicestershire and Rutland is our system. We know that through a bit of research that's been done, LGBTQ plus people across the area, 50% of them in a recent survey said that they had some form of depression. And it made me think about, so what is sitting behind that? What are the reasons why my community is more likely to be depressed? And it is because when you look at the information, that there is no service that responds to our different and unique needs. So you can imagine if you're in a service that doesn't meet people's needs, then it doesn't move things forward for those users that need it. So this is where that co-production element really can make a difference for them. I just wanted to also point out, and to underscore the point I just made, it's really getting to you into a place of working with diverse communities. I think in the past, we've had a situation where it's been the same group of people that have been consulted with, or the same group of people that have come to a meeting and said, we like this and we don't like that. We've got to move away from that. Co-production is at the very heart then of delivering engagement and involvement with diverse communities. And I just make the point on my slide there that we mustn't forget that tackling health inequality is a priority for every single ICS in the country. That's what the government has decided. You're only ever going to tackle health inequality through co-production because it's people within communities that know the solutions for where they live. And finally, I don't know how many of you are aware, but NICE published guidance on shared decision making, and it recommended a number of things. So it looked at how do you most co-produce at that individual level, which is what it describes as shared decision making, but also at that more strategic level as well. And it recommends the creation of a patient director role with lived experience. So there is something there about organisations being able to use NICE guidance to really power this agenda forward. Next slide, please. So my sessions are always interactive. We're going to split you all into groups. We've got about 15, 20 minutes to do this. There are 3 tasks that we're going to go through. So in your groups, just talk about what experience of co-design and co-production is. What have you found to be some of those barriers that really hold engagement and involvement back? But also, more in particular, what at this particular higher level, what have the barriers been? And then I'm going to ask you to discuss how you overcome those barriers. And once we've done that, we'll come back together as a group to reflect on all of that. So Lade, the group that you're in, what were the sorts of key things that came out of that?
Well, we had a really rich discussion despite the fact it was really quite short, a short time. The things that came up were fear, and the fear that what's going to happen if you have the different groups of people in the room, and the absolute key thing, which is that you actually have to do preliminary work to do co-production well. You have to plan for it, and from the outset, you need to have all the people represented, and there has to be recognition that that work that needs to be done to facilitate people to work together might take a while, and it might mean doing work with people so that they can be effective in the room together. And so Chitra talked about, you know, because we often get it wrong before we get it right. We've all done that. Very much about how getting the ingredients right, engaging people, asking them how they want to work with you, and Ross spoke about work that she's done in the Department of Health, putting disparate groups together, and actually it really didn't work, and having to then really work with the groups separately and then bring them together because we wanted to do the same thing. And Claire particularly spoke about the importance of being honest, and being honest from the outset with people about what's possible and what's doable, rather than just sitting. And one of the biggest problems is when people say they're doing co-production, they sit in the room together. You've got the person who uses a service and you've got the person who delivers a service nodding away and then going away and just carrying on as usual, when in fact they're not really doing anything because they've been asked about stuff that's not necessarily realistic, and how important it is to be honest and realistic about what's possible. But a big thing was about preparing people to be able to work together, therefore facilitating their engagement, and that's absolutely key.
Yeah, so what I'm hearing is something around values and relationships being at the heart of all of this.
Yeah.
Pretty, would you like to summarise just briefly what we discussed in our group, those barriers?
So in regards to barriers, we spoke about resources, how there can be a lack of resources sometimes in doing some of these engagements. I'm really sorry, I can't remember the other lady that was within that group, Laura. Laura mentioned a lot of the issues in regarding sometimes being within a certain organisation and then engaging with communities as well, certain particular communities.
And the other one was agenda, wasn't it? That the barrier can be that you start off with an agenda in the first place, and the people that you're supposed to be doing the co-production are well aware of there is an agenda before they start. Yeah,
definitely. So an example I'd given was that we were commissioned to do some work with the CCG, for example, and if the agenda was kind of given to us, it wasn't really co-produced with service users per se. So yeah, those were the main barriers for us.
Yeah, no, when we'll, before we sort of finish this session, we'll think through some of those ways of addressing those barriers. I'm going to pick on one more group. I'm going to go to, is it Claire Chapman? Are you there, Claire?
Sorry, I'm on mute.
Yeah, so what were you discussing in your group?
We were really sort of discussing the sort of what you need to put in place to make sure that co-production is effective, and we talked quite a lot about the work that we would need to do in preparation for that. So identifying the people that potentially would want to be involved, and making sure that they'd got the support in place to engage effectively with that.
Yeah, so the kind of infrastructure behind it. Is that, yeah,
because that's really important, isn't it? Because otherwise it can be quite a negative experience for people if they don't have the right support.
Yeah, no, absolutely. Yes, and I think again it goes back to those values and relationships. So what is underpinning the support that they receive? Great, so go on to the next slide, please. So here are just some quick tips on co-production. The first one I originally wrote, and it was a bit of a tongue twister. So what I was saying originally was co-produce your co-design and co-production. Basically, work with patient and carers to design what co-design and co-production looks like within your organisation. I think in a future session, I'll be talking about integrated care systems a bit more, because I know that areas are increasingly looking at what does co-design and co-production look like across a system, but it should be at the heart of that relationship with patient and carers that have been there from the very start. I would recommend always creating paid lived experience roles, and it was absolutely fantastic to hear earlier on that had happened in a few areas. It's really important actually, because the people that you would want to get involved from diverse communities may not be in a financial position or have the confidence to volunteer to be involved with this sort of work. So it's about recognizing their value in time through payment. And there are national frameworks that NHS England have written to help inform that. Like I said, NICE guidance talks about senior level ownership through an executive level patient director. So that is a very senior role that would be in those executive meetings. But that is not just a kind of member of staff that people apply to. One of the core criteria of that role, promoted by NICE, is that person should have lived experience of those services. I always say training programs co-production is fundamentally important, because that can help tease out a shared understanding of the same language that you need to use when talking about it in your local area, and bringing in kind of external facilitators to help make that happen, but getting your patient and carers to deliver some of that training program too. And just one final bit on this is kind of having a wide project board table. Again, we've seen that happening in a number of places, but this final point is about making sure that your patient and carers are equal partners in this environment. And what I want to remind you all of is actually you do have the power to make it happen. So use that power to really make a difference on this. Before I go to my final slide, someone spoke to me about resources, and I think this is a really important issue. So yes, co-production, for it to work well, it does cost money, absolutely. But I would remind everywhere that actually through the mental health investment standard, through a number of other investment pots this year into mental health, if you could work with your clinical commissioning groups, potentially top slice some of the money that's received to invest it in co-production, that might work really well. And it's something that I've certainly been doing locally with my clinical commissioning group. Right, next slide, please. So just in conclusion, there are a number of resources out there to help you with this. The Royal College has a resource called Working Together, which it completed work around on it in 2019, which is all about co-production. And this is one of the quotes I just wanted to take from it. So you'll see at that point in time, Bristol, North Somerset and South Gloucestershire CCG had a dedicated commissioning post on co-production for mental health. And it really led to this kind of independent, co-produced feeling about the world. So just to say, it does make a difference if you do co-production well. And what we'll do in a future session, we'll do a bit more on co-production, I'm sure, in another one of these sessions in the future, to really unpick some of that. How does it look like within an ICS system in relation to this project? But Thank you, everybody. I hope that's been useful, and hand back over to Tom.
Thanks so much, Mark. And yeah, I'm pretty sure we'll be talking about co-production in future sessions, and hopefully actually hearing more examples of how people are talking to their communities in this work. I think, you know, the greatest learning is learning from other people doing things with this sort of thing. So that'd be great. Thank you so much for running that session, Mark. It's been really another great session. There's a comment from Michelle in the chat about terminology, and Michelle saying, can we say people rather than patients, carers, service users, clients? Really important point, actually. And one of the things that we, when we were developing our work, it's actually called Working Well Together, Mark, not working together. We have higher aims than just working together. That resource is that we talked about that terminology, and we said actually it's really important when you're doing co-production to talk to the people you're working with about terminology and about that sort of thing. And so my personal preference is to talk about people who use services, or people who you have mental health problems or suffer with mental illness, rather than service users, patients. But that's just me, and other people have different preferences. And I think it's good to have that conversation with people to find out how people want to do that. Satwinder, you had your hand up, and I wondered whether you put it down now.
I did have my hand up, and yeah, time, I've put it in the chat as well, but I think it can happen because, you know, where I am, East London Foundation Trust, we have actually co-produced, co-designed, and I do co-deliver co-production training, and we do have a system where involvement begins with people participation team, which is quite unique, I think. And that actually allows service users to kind of get involved in all aspects, and then enables co-production. So, you know, it is about building those relationships, trust, time, and also sustaining the financial side of things. But it can happen. But I do think, again, you know, professionals as well, I'm a patient, whatever, but I think professionals and clinicians need that time as well, and things to be in place for them too, because I think sometimes it's more frightening for them.
Yeah, and I think it's really important to think that people often work into unrealistic deadlines if they're expected to co-produce work, and I think that and that puts pressure on staff. And I think that people who are leading projects really need to think about that in terms of their timescales, and hopefully are doing with this work. But it's a really important point. So really, thank you for that. So we've reached midday. It's the end. What a great session it's been. Really amazing presentations. Thank you so much, Uju, Helen, and Amrez. And then for the panel discussion, Lade, Laura, Raj, and then Mark doubling up on the panel and leading that fantastic session on co-production at the end there as well. Thank you everyone for your involvement. It's been a really lively chat, and the sessions were great. So we will see you again for this sort of session in about 3 months' time.